Good afternoon, everyone, and welcome to the 38th session of MOH's HIV ECHO program. And today's discussion, we are going to look at rapid insertion of ART. But before we go through the topic for today, we shall introduce ourselves. I can see a number of facilities which have joined. And with me in the hub, I've got a number of people have joined, and we are privileged that in the midst we have got Professor Lloyd Mulenga, who is with us here. We've got residents from infectious diseases, HNP providers in ART, and others. I can see that a number of facilities have joined, and I think we have done the testing already. I wish to welcome you all and encourage everyone that we should participate in this important topic, which will be looking at rapid insertion of ART. The session today, the didactic session, will be presented by Dr. Sivile Suilanji, who is not with us here in the hub, but is in Livingstone, but will be able to connect through the platform. Before we go into today's session, I will invite Mrs. Priscilla Makupe to give us a recap of what we discussed last week.
Last week's ECHO session was on tuberculosis preventive therapy, and it was defined as treatment offered to individuals who are considered to be at high risk for TB disease. The aim of TPT is to reduce the risk of TB infection progressing to active TB. In people living with HIV, the risk of progression from infective tuberculosis to active tuberculosis is 10%. Therefore, it is important that we commence the new cases who are commenced on ART, including the old ones on TPT. We also talked about the national target for TPT, which includes to start all new ART patients on TPT. We talked about the eligibility criteria, which includes new patients on ART, patients already on ART, and TB contacts of all ages. These are individuals, they have to be screened for active TB before they are commenced on TPT. That is very, very important. After assessing them, if they are not showing signs and symptoms of active TB, then they qualify to start on TPT. If they're assessed and they show signs and symptoms of active TB, then they have to start TB treatment. After initiating TPT, it is important that we monitor these clients for adherence, for side effects, and also to assess them for signs and symptoms of TPT during the course of 6 months. So the review dates for these clients is at 2 weeks after initiation, and then at 2 months after initiation of TPT, and then lastly at 6 months. We also talked about creating patient demand, which includes raising public awareness about TPT. It is a responsibility of us healthcare providers to ensure that we give IEC to the clients and also to the public sector so that they are aware about TPT. We are all ambassadors for TPT. It is not a one-man show. All of us healthcare providers have to be involved. We also talked about commodity management, which involved ordering of INH and B6 on time. We should not wait for the commodity to finish and then we order. We have to make sure that we have the drugs available at all times. Thank you very much.
Thank you very much, Madam This is Makupe for that recap of last week's session. Without much ado, I will invite Dr. Sivile, who is going to take us through today's didactic session. Dr. Sivile, are you ready?
Can you hear me, Dr. Mpeta?
Yes, we can.
Okay. I'm here with a team, with a spoke in Livingston Central Hospital.
Okay. Are you able to see the screen?
Yes, we can. I can see the screen, Dr. Mpeta. Thank you.
Yes, please.
Can I proceed? Can I proceed?
Yes, Dr. Sivile, you can proceed.
Okay, thank you. So today we are going to discuss a rapid initiation of ART and preparing a patient for lifelong treatment. And that's my name. I've got no disclosures and I work for University of Maryland. So some of our objectives or outline is we want to discuss why same-day initiation, barriers to same-day linkage, overcoming these barriers. We look at barriers to retention, overcoming barriers to retention, and monitoring adherence through viral load. Next slide. So we can have a polling question. Dr. Mpeta, you can take us through that polling question, sir.
Yes. So a 32-year-old man tests HIV positive in OPD. He has no signs of crypto or TB. The CD4 count was 420. RPR, hepatitis B were negative. He completed ATT about a year ago, and he refuses to start ART. Liver and kidney are okay. When should he come back to the hospital? So we can, Paul. So this is a 32-year-old man who tests HIV positive in OPD. He had no signs of crypto, meningitis, or tuberculosis. His CD4 count was 420. RPR and hepatitis B were negative, but he had completed it a year earlier than at presentation. Then he refuses that ART. Then his liver and kidneys were okay. The question is that when should he come back to the hospital? Can we keep the votes coming?
What's the answer here?
Isn't it within 14 days?
Okay, thank you very much. We shall try the second one.
14.
So is the clinician
That's fine, we have submitted already.
The second poll question is, in which of the following patients could you delay rapid ART insertion? A, patient with cryptococcal meningitis or herpes simplex virus infection. B, patient with herpes simplex virus infection or pulmonary tuberculosis. C, patient with cryptococcal meningitis or pulmonary tuberculosis. Then D, patient with herpes simplex virus infection or oral candidiasis.
C.
So we can go ahead with the poll. The question again is, in which of the following patients would you delay rapid insertion of ART? A, patient with cryptococcal meningitis or herpes simplex infection. B, patients with herpes virus infection or pulmonary tuberculosis. C, patients with cryptococcal meningitis or pulmonary tuberculosis. And D, patients with herpes simplex virus infection or oral candidiasis. Okay, we've seen a number. Okay. We can go to the third poll question, and it reads, all of the following are a benefit of rapid insertion of ART, except reduction in HIV transmission, B, reduction in HIV progression and occurrence of life-threatening opportunistic infections, C, reduction in all-cause mortality, and D, increased linkage to care.
D.
So I may repeat the question. All of the following are a benefit of rapid insertion of ART, except reduction in HIV transmission, B, reduction in HIV progression and occurrence of lifelong opportunistic infections, life-threatening, opportunistic infections, D, reduction in all-cause mortality, and D, increased linkage to care. Only a third of us have polled so far. Okay, thank you very much. We shall come back and review the poll questions. Dr. Sivile, you may pick it up.
Yes, thank you, Dr. Mpeta. And the last question was a tricky one. I could see people were hesitating. Yeah, so we'll start with some definitions. So linkage to care is the first step in engaging HIV care and is defined as the completion of the first medical visit. And usually in this country, we look at it as the opening of the initial history and, initial history, assess and physical exam, the so-called IHAP form, and this will come with obtaining the ART number and dispensation of ARVs. In other places, they look at other parameters. They will look at the first CD4 count result, the first viral load, and so on. Yeah, and we expect this to be done within 28 days after HIV diagnosis, and this is the cutoff point, at least in the linkage register. So WHO and other literature in research and so on does define rapid initiation as commencement of ARVs within 7 days. And preferably this should be done the same day of HIV diagnosis. So ensuring rapid linkage to care and initiation of ARVs on the same day of diagnosis is actually a key component of us controlling the HIV epidemic in Zambia. Next slide. Next slide, Dr. Mpeta. Yeah, so this is from our guidelines. You can see there that actually we look at two things before you initiate the same day ART, or algorithms look at one should exclude TB and exclude cryptococcal meningitis. So as it stands, those are the only inhibitor or things that should prevent you or contraindications from starting ART the same day. Next slide. So this is just an algorithm which is a bit clear. This was used in a study called the SLATE one. So really you need to have symptom report for TB, a brief medical history. Here in our setting, we emphasize, we look at things that can point to renal disease because we look at, we use tenofovir, so we look at diarrhea, hypertension, weight loss, and things like that. things that are risk factors for renal disease. If those are not there, you can do a brief clinical exam, and you also look at readiness assessment. Probably this is where difficulty comes in. How do you define that someone is ready? Yeah, so if they are ready, you proceed and start ART the same day. Next slide. Next slide. Yeah, so why same-day ART? So same-day ART actually prevents all-cause mortality, and this is a very important part of information. It improves patients' immunologic and virologic outcomes, improves retention, and also prevents transmission of HIV and also just HIV incident. We know this from the POPAT trial. So what is missing there actually is same-day ARTs to talk about progression of disease and OI. And this we learned from this trial, the START trial, published in 2015. So this trial shows that, that's on your right side there, which shows that there was a 57% reduction of all serious adverse events or death with the immediate start of ART. So this is not just death due to OIs, so it's death due to anything else, cancers, So we are not really trying to prevent OIs, and that should be very important. You are trying to prevent death or cause mortality. So that's very important. So this trial just shows that linkage actually improves, when you start patients immediately. This was done some time ago before we even moved the guidelines. It was called RAPID, RAPID done in South Africa. You can see that site that, linkage goes up. If you start patients the first day, or early enough, within 7 days on ART, you have more people being put on ART. I think that is straightforward. Yeah. But of interest in this trial, you can see that somewhere down on that diagram on the left side here, that you find that in those who are started earlier, there seem to have been less people retained in care. And this is consistent in a lot of other, programmatically observed data. At least CIDAS has presented something like that. University of Maryland has presented something like that, and I'm going to discuss that. So we know that starting patients earlier will make more patients get into care, or start the ART. But apparently, patients don't do well in terms of returning them into care. Next slide. Yeah. So what are some of the barriers to same-day ART? So this can be thought of patients' factors, disease factors, and caregivers' factors. So the commonest patient factor is psychological issues, not ready. And we hear this every other day when patients are diagnosed, when the patient says that I'm not ready to start ART, when you insist that they started the same day. But what does it actually mean? So this needs to be slightly unpacked. So really, patients do have these fears, for fears over stigma, fears over shame, fears over side effects, and a lot of other things. But I think the take-home message I'd like to give here is these fears are things that should be sorted out by the caregiver, as opposed to just saying the patient was not ready. What do you mean? And I'm going to talk about readiness a little bit more, Yeah. So there are disclosure issues which can act as barriers, alcohol use, drug use, and structural things, common things like transport, finance, poor support, which is a very important things that we've talked about in the past, looking for a body, time to come to the facility. That is because of their type of work that they have. Disease factors. This is some people who have opportunistic infections, as we've mentioned. There's so into good outcomes, and people have suggested things like patient escorts. That this helps case managers, people who are helping with patient navigators and so on. These are, help to overcome community initiation. In other words, where someone is doing an HIV test, at that point they should be able to commence ART. This will prevent, problems with linkage. Integration of ART services, we've talked about that for a long time. DSDs, things like after hours, weekend, because some of the barriers are actually time constraints and how people work. Some literature does suggest provision of some support like transport and so on. This has been proven to work actually, and we should also be thinking about linkage systems for key populations, adolescents and men. These do have unique barriers for them to find care in our facilities. Next slide, Dr. Peter. Next slide.
Yes, it's coming.
Next slide.
It's coming.
Yeah, so you'll find other things like, strength-based case management. This is just some psychotherapy kind of approach, intensive outreach. Index testing does help with linkage because there's that extra engagement, and in facility settings, some people just don't come for initiation because lines are too long, and some people have suggested shortening waiting time for new clients. Now, those clients who are coming the same day, why don't we give them kind of a special package, to encourage them so that they don't spend too much time. I wanted to point out on the fear of iris. I hear this a lot, that I didn't start the patient because we were suspecting maybe there's an OI and so on. So the key to this is really good assessment of the risks for those iris and also possible time of infection. You see, most of these patients that we are diagnosing, most of them will usually have good CD4 counts that are not on the lower side of immune suppression. So, if you can ask someone that maybe I did a test last time 2 years ago and I didn't have HIV, they think they got infected a year ago. There's no way you can be scared of iris in that case, because we know that iris, usually happens when the CD4 counts are low, Yeah. So a good history, good assessment of when the person got infected is a key, to these fears. You can rapidly initiate patients. Clinical staging, when you stage a patient, someone is in stage 1, asymptomatic, just a bit of lymph nodes here and there, possibly you shouldn't be afraid of these other big cryptococcal and so on. You can go on. But so good history taking and physical exam, cannot be overstated. But really when it comes to iris, the key is close monitoring. You are not starting ART on this patient and throwing them away. You see to see if this iris is unmasking or so on, so that you can treat it. And by and large, we know that mortality from iris is actually low as opposed to mortality from not giving ART. So there's no reason to wait. So preparing a patient for lifelong treatment, what does it mean? This is from an old book, which AIDS Therapy 3rd edition, and it was done in 1999. And it probably summarizes what things that we should be talking about when we are initiating patients. But I'd like to say that this is usually a team effort. So some of these lapses that we are seeing is you have, just one person, maybe a clinician with no proper counseling, or they don't have good counseling skills, no pharmacy people on board and so on. But it should also be pointed out is that preparing a patient is actually a continuous process. It's not a one-time event. So once someone is diagnosed with ART, what are you supposed to look at? You are supposed to be assessing whether the patient is ready to commence therapy, And this really, you are assessing for the presence of the patient's disease and healthcare barriers, things that we are talking about. Those barriers are explained. You want to see, are they there? And how do I help a person sort out those barriers? So really, you should take some time to talk to these patients. What fears do they have? Are they afraid of stigma? You talk about that. Are they afraid of disclosure? Are they afraid of side effects? You deal with those things. See if they are there and how you deal with them. This is how you prepare a patient, for lifelong treatment. You have to give this patient basic education about HIV and available treatment. Then you talk about issues of adherence, side effects, comorbidities, and also important, you need to address issues of transmission and reproduction health. Some of these patients, they need to be on contraceptives and so on. So, in a nutshell, that's how you prepare a patient for lifelong treatment. So, how about retention? Retention is really keeping the patient in care, So, what are the barriers? So the barriers are really similar to the ones that are for linkage. But here we know that health system or quality barriers become exaggerated. They are prominent than in linkage. So this speaks to what is happening in our facility. Why are we losing patients? So why are we so confident about this? We know several studies. The beta info studies done by SIDA shows a male characterization study, and some of the evidence we have from GSD implementation does speak to the fact that system or quality issues in our centers are actually a bigger problem when it comes to retention, or a bigger cause, or for retention. And therefore, the main question we should be asking ourselves is time a major determinant, or can we still do a quality job while implementing rapid ART initiation? So why are we seeing these patients who are rapidly initiated falling out? Is it an issue of just time, or can we still do a good preparation of patients even on the same day? And that question, probably none of us has got good answers. We might need more studies to answer this particular question. Next slide, Dr. Mpeta. Yeah, so these are just some of the causes that came up from the beta info studies, which had to do with, systems issues, some causes of loss to follow-up, and we can see most of them have to do with, our attitudes, healthcare, things that happen in our facilities. Next slide. Next slide. So some of the remedies for poor retention, DSDs would help deal with the issues of, of quality in these facilities, congestions and so on, time issues, yeah. But good psychosocial supports as well, these are, increased or accentuated in DSD support activities, but really, we need to now start thinking of quality standards for ART services. So this is not only talking about what services we should be offering to these patients, it's really how are we supposed to be offering these services? How is counseling supposed to be done? How are we supposed to be monitoring these patients? I think we need some more work there. Quality standards, of our ART services. Continuous training and mentorship is key. We need to continue doing this, and most, the other issue is improvement in M&D systems. And I'm sure all of us who are dealing with ART patients who see these, drop in treatment car and so on. I think we need a consensus. Is it 30 days? Is it 60 days? And so on. Let's find the good measurements and improve our MR. I know there are a lot of issues when it comes to how do we monitor retention. We need good M&D systems. Next slide, Dr. Mpeta. Yeah. So concerning patients' readiness and viral load, so we know that viral load is the best method for measuring readiness and adherence over time. So there's this question, how do you know that the patient is ready? And a lot of suggestions have been given. We always give these instructions. Before you start ART, make sure that the patient is ready, but no one does explain what is being ready, and a lot of research has been done, using psychological methods and so on. A lot of theories are there. But this gentleman in 2010, Grimes, did, a meta-analysis of everything, including recommendations from WHO, and he published this paper, which I like, The State of the Science of Readiness, or the Lack of Science. And really the conclusion is, there's no good, measurement of how the patient is, whether the patient is ready or not. And I gave this quotation as my closing remark. So the concept of readiness is viewed by both researchers and guideline writers as a one-time concept dealing with initial therapy or relating to adherence at some point to the patient's course of ART. The reality of antiretroviral therapy is that readiness is an over and over state of mind. Each day, multiple times per day, HIV-infected patients must be ready to take their pills. Patients must be ready to initiate therapy every time their prescriptions run out. They must be ready to call and order prescriptions or to attend clinic to obtain renewals and be ready to go to a pharmacy to pick them up. Life circumstances change, and barriers and facilitators to readiness will disappear and reappear over the course of the patient's life. So in a nutshell, readiness is not an event. It's something that you need to engage with patients over and over. And this is where probably the ball is dropped. So the key points to this presentation is good counseling and good support will result in better patients' outcome. A lot of evidence to that. And so the money is really in us finding time, and spending time with these patients. Find out what are the barriers these patients have and how do we solve those barriers. That's where the money is. Of course, we need to strengthen DSDs, and we need better tools for quality standards. I think these need to be developed. I know there is some work from MOH to develop quality standards to tell us how is counseling supposed to be done. Some doctor went for an HIV test about 3 weeks ago, and she had a very bad experience. So we need quality standards. We might need to come up with better patient readiness assessment tools or give some guidance of some sort, and mental health assessment tools are important. I know from psychiatry and psychology, they have these tools which they use to check if is someone depressed, is someone, those tools we need to get them. How many times do we refer patients, because they are depressed before they're starting ART or in the course of treatment? As you know, life events change, and that's how patients drop out and drop in. So that mental health, help, I think is something that we need to strongly incorporate in our ART service, and I'm glad I'm just seated next to a psychiatrist here. Next slide. Next slide, Dr. Mpeta.
That's the last slide.
And so that's probably we haven't given, big lessons or a silver bullet of how to sort out retention, but these are the guides that you find. And I think the most important thing is good counseling and good engagement with each patient. And I'm sure Dr. Mpeta works with me in third line clinic. I think he's seen this several times. If you spend time with patients, counsel them properly, the outcomes will be better. Thank you very much, Dr. Mpeta.
Thank you very much, Dr. Sivile, for that well-explained session. We will now revisit the poll questions which we had to just ensure that the retention is actually there. So we'll start with the first one. And the first one was about a 32-year-old man who tested HIV positive in OPD. He had no signs of crypto or TB, and the CD4 was 420. RPR and hepatitis B were negative, and he had just completed ATT about a year ago, but he refused to start ART. His liver and kidneys were okay. When should he come back to the hospital? So this is where we are. Okay, we still have very few people have polled, just under 30%.
But preferably within
7 days.
Okay, so Dr. Sivile, we are ending and I'm sharing the results. So we've got about 82% who have gone for 7 days, 8% have gone for 14 days, and about 10% have gone for D, which is within 28 days. Your comments?
Yeah. So yeah, the answer is 7 days. We want these patients to be started on treatment, you know, preferably the same day, but at least within the 7 days of treatment. So immediately, really. So the best answer there is 7 days, I agree.
Okay, so thank you, 7 days it is. So we go to the second poll question, which reads as follows. In which of the following patients would you delay ART, rapid ART insertion? A, patients with cryptococcal meningitis or herpes simplex virus infection. B, patients with herpes simplex virus infection or pulmonary tuberculosis. C, patients with cryptomeningitis or pulmonary tuberculosis. And D, patients with herpes simplex virus infection or oral candidiasis. Okay, can we keep on polling? Okay, so we've got about 50% of the participants who have. I think here we seem to have a unanimous decision, which is C, cryptococcal meningitis and pulmonary tuberculosis. Dr. Sivile.
Yeah, this is so encouraging.
Yeah.
Our patients are in safe hands.
But we don't know about the other 50%. What happened to those who didn't make the poll? Does it mean they are afraid to poll? All right, the last poll question. Of all of the following are a benefit of rapid insertion of ART, except A, reduction in HIV transmission, B, reduction in HIV progression and occurrence of life-threatening opportunistic infections, C, reduction in all-cause mortality, and D, increased linkage to care.
I think this one will correct.
So which one of the following are not a benefit? That's what the question is saying.
Yeah.
So 3 are a benefit of rapid ART insertion, and only 1 is not a benefit. So please pick one which is not a benefit.
Reduction.
I remember he's making
I'll spend a few seconds on this one. We still have less than 50% who have polled. Can we please poll so that we see what the other 50% are thinking? Other Davison, we haven't seen you poll. No one has gotten up. Remember, we can see you from here. Okay, Dr. Sivile, I am sharing the results. The majority, about 67%, have gone for D, and then about 24% for C. The list is A. your comments on this as well.
Yeah, so this is heartbreaking because I got a DSA to Livingston to come and teach this, and I need to take back the money. It seems people haven't heard the lesson. So this is one of the take-home message that I want you to get. The answer is actually B, the one that has scored 9%. So this is I think the biggest misconception, and it's the message that we want you to tell the patients. So when you are, why you need to start someone on ART? It's not that, you want to prevent OIs or progression of HIV. No. So we know now, we have evidence that even without OIs, even with a CD4 that is 100, that is 1,000, above 500 in the study, that patient is at risk of death or cause mortality. As long as you are on you have HIV and you are not on treatment, even if your CD4 is fine. If we look at those who are treated and those who are not on treatment, death is higher. So Dr. Mpeta, you can probably flash the slides with a START trial, So this was one of the, probably in the last few years, the biggest trial that one of the most important trial we've seen, So the message is, we are putting patients on treatment to prevent them from dying or cause mortality, to help them to care fast. Because if you don't put them on treatment faster, you'll be losing them. It's like you are catching a fish and dropping it back into the water, And again, we know that if you put patients faster on treatment, somehow, I know the POPAT findings are controversial, but we would like to believe that, you are actually reducing transmission and incidence, not that you are trying to prevent the patients from getting serious OIs. So the objective, patients should know that we want them to be alive, because all-cause mortalities, including dying from strokes, cancers, and so on, are higher. And the reason is probably there is continuous, when the viral loads are higher, you are not on treatment, even your CD4 is high, there's a continuous inflammatory activity in your body. And that, persistent inflammation is linked to cancers, is linked to heart disease, is linked to all sorts of things aside from OIs. So if you have time, the START trial is an open source. You'll find it on the internet, but it will show you that actually the patient should know, when you are counseling a patient, know that if we don't put you on ART, you will not die from OI, but your risks of dying are higher than someone that if we had put you on ART, even if the CD4 is fine, even if you don't progress to OIs, even if you don't get TBs and cryptos, the risk of dying is higher. So the answer is D. Please, I hope you got that lesson. And the patient should know. B, sorry. And if we have the right information as caregivers, we'll counsel the patients better and convince them to be on ART the same day, because it's important. There are some studies which shows that even a delay of 40 days gives irreparable damage to the immune system from the time you are infected to the time you start ART. So starting ART is always beneficial if you're starting it the closer you are to the day you are infected. I didn't want to go into those details, but the answer is B. Thank you, Dr. Mpeta.
Thank you very much, Dr. Sivile, for those elaborate explanations. As we are getting Nangogo to get ready and share the case for today, I will allow a few clarifications or comments from the network. I haven't seen any hand. Please, if we have got any clarifications or any questions with regards to what has been presented by Dr. Sivile. Dr. Sivile, maybe as we are waiting for people, maybe just try to emphasize on this. You identified one of the barriers to same-day ART as caregiver factors, and one of them is actually knowledge. And, with relation to what we are doing, with the ECHO program, how do you think the impact is going to change, especially on the aspect of knowledge and attitude? Do you think we are winning in that regard, or do we need to come up with other innovative ways?
Yeah, I think knowledge, the ECHO program does cater the knowledge. As you can see from the last poll question, we are correcting some misconception. So I think we are improving, yeah. Concerning, attitude and conception, there are probably some other tools, like I've said, quality standard tools and so on. All those needs to be done as well. On the caregiver, we need to give these instructions. If you are counseling someone, what do you need to look for? That sort of information. How do you do the counseling? The way they do it, these people who do advertisements on advertisement, in the commercial area, you need to smile. If you go on the plane, those air hostess people, they always smile at you. Do we smile at the clients? Is there an SOP for how to smile at the patients when they come into the ART clinic? We need things like that. Those are standards, what I mean. Then the attitude will change,
Okay, thank you. So there is a hand from Kapata Urban Clinic. Kapata, please go ahead.
Good afternoon.
Good afternoon.
Sorry, you can't see me where the mic is and where the camera is. It's there's a bit of a distance.
We can hear you loud and clear.
Okay, Nsamanyendra is my name. I'm a bit confused about the answer for the polling question, where the third one, where he said the answer was B, because I was almost certain that the whole essence of starting ART early is to prevent progression of the disease. We want our clients to stay in stage 1 and prevent other OIs, and that's how we're going to prevent death. How do you prevent death if you don't avoid the OIs and you allow the disease to progress? Thank you.
Dr. Sivile, was the question clear about
yes,
the
it's
third
clear.
question?
Yeah, so I think that's where the understanding should be, the explanation should be probably robust. So if you remember, my colleague from Kapata, that initially we used to start patients at CD4, 350, 500, 200, and whatever. The idea there was start someone at 350 CD4 so that they don't progress. But then there was this study which showed that, that's the START trial, they randomized patients. One arm, or everyone had CD4 above 500. Others were started on ART, and others were not started on ART. So if your CD4 drops below 500, you'll be started on it, you are moved to the other arm. So they were looking at people who had good immune system, people who didn't have OIs. And when the results came out, it showed that even with a CD4 that is fine, even without OIs, there is more death in people who are not started on ART. Adverse events are many in those people who are not started of ART, regardless of those who are not started on ART when they don't have OIs. So currently, the issue is not OIs. The issue is not progression of the disease. It's the fact that HIV is a disease, and probably the best thing that you need is a cure. Outside of the cure, it's immediate ART before you even progress. So that concept of, let's let the stages roll down and then we treat seems not to be a good idea. So that's where the lesson is. I don't know if Dr. Mpeta can help me with explanation.
Prof, okay, I'll give actually Prof to help with that explanation.
Thank you, Dr. Sivile, for the wonderful presentation. I think, as you have rightly said, the emphasis on immediate ART should be placed on the fact that any day that you delay, it's not just a progression of HIV in terms of opportunistic infections, but also that there is a permanent immune damage which happens even when there is no infection which someone can see or diagnose. There are also a lot of conditions that may come in, which may not be related to the CD4 value. Someone may have the anemias, the thrombocytopenias, the nephropathies as well. And all those are related to the HIV disease. And you need to have interventions which are done early. Whereas my colleague from Kapata is in a way right. There could be further progression of infections as well, which you need to combat. But what you're looking at is the whole perspective of the immune damage which HIV does. And because of that, you need to have an intervention early. It's not just towards the infections which the patient may present. Now, when should you start ART? And I think he has clearly elaborated the situations in which you need to delay. But the emphasis should be that even in those, you have to be very cautious on when you decide to delay. The more you delay, the outcomes would also be worse if you delay further. And I think the issues of malignancies as well, which may not be related to the CD4 as well, would be increased if you do not start ART.
Thank you very much, Prof. There's actually a similar question from Suilanji, which is saying the diagnosis of HIV is really a psychological issue. So isn't it too much that after we make a diagnosis, you start the client on ART, at the same time you start following them up for index testing and all that? So any thoughts, Prof. and Dr. Sivile?
That's what you do with TB.
Especially in line with preparation for the patient to start ART. Yes, Prof.
So really, what we have seen, and I think there was also some evaluation, I think I looked at a paper from San Francisco, where those patients who were started on treatment early, immediately after diagnosis, the acceptance, in fact, was better than those who delayed, but of course, even the overall outcomes. Yes, what we need to understand is the fact that when someone gets that information of HIV, being infected with HIV, being positive with HIV, it does take time, but most of the times people know about HIV and they may even have a suspicion that they may have had HIV. And also right now, there's a lot of talk over HIV in terms of the treatment, which gives someone a good life, that HIV can be controlled. So people are really ready for them to be started on treatment. There are very few individuals who take that very, very negatively. If you start on treatment, you think that even the fallout is going to be higher. I think what you need to emphasize is the fact that when you start someone on, if they have HIV, start them on treatment. You start them on treatment. If you prepare them well, even when we say immediate ART, I know there was a lot of discussion when we brought in that a few years ago. We do not mean that someone who may not be ready to start them on treatment. Someone has to be assessed on how ready they are, and usually the acceptance is very high. Dr. Sivile has worked so much on even the contact tracing and index as well. We thought the same way that if you find someone who's HIV positive, they may not give you the contacts. What they are finding out there is that they would willingly give you the contacts. And even when you find those who may be positive, also the linkage is also quite good and also quite high, and even the acceptance. So sometimes I think it's because people were thinking this is a death sentence and people are not ready. Usually the acceptance is high, but we need to prepare them for long-term treatment. I don't know, we have Professor Eli Kamodi from New York. Is the experience different?
No, I think it's very similar. I think that people, as you mentioned, they often have an idea that they have the diagnosis even before they're actually formally tested. and they're very accepting of treatment, at same-day treatment. And I think another sort of a factor that we've found to be motivating for people is, the data that's about U equals U, or, undetectable as untransmissible. And I think people are motivated to not only protect themselves, but to protect their loved ones and to get undetectable as quickly as possible. So I think, that's the only thing I have to add, but I think the experience is similar.
Okay, so thank you very much. And I think we will have some more discussions with the case which is coming. So I will ask Nangongwe to start sharing. We'll share from here. Okay, thank you very much. So Nathan and Mundia Kota. Okay, please, you can stop sharing from that side. Thank you.
Okay, so good afternoon, everyone.
Good afternoon, Nathan.
I hope everybody can hear us. So I'm with the team at Nangongwe Clinic. And so Mundia Kota will take us through the presentation. So next slide, please.
Okay, good afternoon. On the history, male 31 years old, married to a HIV positive woman on ART at another facility, and has a 7-year-old HIV negative child with another man, sorry. Presented at OPD on 6th of August 2019, complaining of cough, night sweats, general body weakness, headache, and chills for 3 days. He was counseled and tested HIV positive type 1 on the same day, but not initiated on ART because he was a presumptive TB case. Sputum collected for gene expert on 6 August 2019. Patient asked to come and check for results and do other labs on 8 August 2019. He was prescribed contraceptive 960 milligrams for 2 weeks, paracetamol 1 gram for 3 days, and vitamin B6 50 milligrams for 2 weeks due to lower numbness of the lower limbs. So on 8 August 2019, and today 19th August, gene experts results not ready. Clinical patient looks better, but still having a cough, productive cough. Looked ready and willing to start ART. He was well prepared by adherence counselors to start ART. The counselors are concerned that some of the newly diagnosed HIV positive patients on TB assessment never come back for ART initiation and were lost. So clinicians felt that he was not eligible to start ART until the sputum results for gene expert were available. So today, on the 19th, patient is still complaining of coughing. So on the physical examination, on the last visit, that was last week, August, the BP was 100/70, respiration 18, temperature 37.8, heart rate 78, weight 52 kg, height 172 centimeter, BMI 17.6. All the review system were all normal. So it came on the 8th of August. The weight was 36.6, the temperature was 36.6, and the weight was 52 kg. And today when it came on the 19th, the weight was 54 kg. So the height is 172 centimeter, BMI 17.6. All systems normal. And today's weight, yeah, I mentioned that. BMI is 18.2 for today.
Next slide,
so next
please.
slide. The patient lab results. So viral load is not yet due for viral load. So the CD4 not yet, is still pending. The gene expert that we requested on the 6th of August, twice given error, and RPRH is negative. That was on the 8th of August. So creatinine, LFT, hemoglobin, they're all still pending with the results not yet out. So next slide. So now our questions, number one, based on the circumstances, should this patient be initiated on ART or resubmit sputum and wait for the result to commence ART? Question number two, was it appropriate to start Septrin prophylaxis before the baseline CD4 results were out? Question number three, what appropriate measures need to be taken to avoid losing a presumptive TB patients while waiting for their results? Thank you.
Thank you very much, Mundia, for that case presentation. I will allow 2 clarifications and 2 questions from the network before I ask the experts to comment. So anyone who wishes to ask for a clarification. Okay, so this is a 31-year-old woman who is HIV positive and on ART. She will be told actually that she's got a 7-year-old child with another woman. Sorry, this is a man, sorry. He presented on the 6th with constitutional symptoms of cough, night sweats, and general body weakness with headache for about 3 days. He was cancelled for HIV, was found to be HIV positive, but was not initiated, partly because the clinicians felt that he could have presumptive TB. Expert was collected and the results are still pending. But on going home, he was prescribed Septrin, paracetamol, and B6 because he had numbness in the legs. And he still has a cough to date, and there is no result for the expert. So the questions that we are seeking today is, based on these circumstances, should this patient be initiated on ART, or should we resubmit sputum and wait for the results for the patients to start ATT? Then the second one is, was it appropriate that this patient was started on cotrimoxazole prophylaxis without waiting for the CD4? And then the third one is, what are the appropriate measures needed to take to avoid losing patients with presumptive TB? Okay, so there's a question, I'm not sure where it's from, but asking whether a chest X-ray was done. I think this is from Dr. Chambwe. Was the chest X-ray done, Madam Mundia?
So chest X-ray was not done. Only order was for the sputum.
Okay. Any reasons for that?
I went there in 2000 for 6 months.
Nathan, any reasons for that?
You don't have X-ray? Yes.
For not doing the chest X-ray?
We don't do chest X-ray at Ngongwe Clinic, so we usually send KGH.
So, but as of today, we really refer the patient to the hospital KGH to do a chest X-ray.
Thank you very much. Any other clarifications or comments? Yes, thanks, Prof.
Is there any sputum microscopy that's available, or is it just the gene expert?
Sorry, is there?
Is there a sputum microscopy available for AFB?
Okay. The question is, Nathan, that is there any other tests like sputum AFB which are available at your facility, or it's just expert?
For now, it's only expert being done, and apparently in Kafue, the whole district, we only have one central point for gene expert, which is Kafue Estes Clinic. So all the facilities in the districts have to take their samples only for gene expert at estates.
Okay. All right, thanks. So Suilanji, you can go ahead. Can we unmute Suilanji? Go ahead, Suilanji.
Hello, Nathan. I just want to find out, why is the gene expert results coming as the error?
Would you try to move closer to the mic? Yeah.
Hello?
Yes.
Okay, Doc, I just want to find out why the gene expert result is coming back as error. It has come back as error twice. Is it the sample, the quality of sample, or is it the machine itself? Or is it the lab?
Okay. So you want to find out why the gene expert came out negative, you see? It kept on coming error. Nathan, any explanations for that?
Okay, so yes, we tasked a colleague, one of the mentors, to make a follow-up. Jacob, I'm sure you'll give us a feedback.
Okay, yeah, so the lab, which is at Estates, is the one that runs the samples. So they use the same sample. When they were given the first error, they used the same sample to run the second test, which gave an error again. That is why today when the client came back, was asked to submit a fresh sample.
So in addition to that, really that one I think is from the lab perspective, even us we surprised, we never expected that to have an error, but it's something that came from the lab. We're not really so sure why it was giving errors.
Okay, so thank you very much. Dr. Sivile, could we try to address today's question? So based on the circumstances on this patient with an expert which is delaying its coming out with an error, should this patient be initiated on ART or should they resubmit the sputum? Your thoughts on that?
Yeah, thanks, Dr. Peter. And this is a very difficult question, I must say. Yeah. So obviously there are health systems issues here that we should point out. We need that X-ray done. We need the gene experts done. You know, we need the microscopy done. Yeah, and other issues as well. If someone came with symptoms of a pneumonia or TB, you are not so sure. The approach really is to treat it as a community-acquired pneumonia where you don't have tests, you know, and wait and see. This is 3 weeks down the line. We would probably have some idea there. Was this just a pneumonia and so on? Yeah, TB is common. So it's really in the balance to this patient. One would like to examine the patient, see other pointers. But I'd like to approach this case in an event where everything is done properly. And sometimes it's genuinely difficult to make a diagnosis of TB. You know, even with tests done, you can't rule in, you can't rule out. And my recommendations in that scenario is to start the patient on ART without waiting any longer and closely monitor the patient. Because if it is TB, you know, the iris will pop up and you should catch it early. So I think that's the approach that I usually do, you know. I know there are no proper trials, but I usually institute, and I've never had really a disaster. So I think that the key when you are scared of iris, you know, whether it's a paradoxical iris or whatever, or it's a missed OI as some people call it, you know, the issue is to monitor the patient. So in seeing patients, nothing should replace close monitoring. You know, the clinicians to start and watch what's happening to these patients. You know, so that would be the approach. I think 3 weeks is a lot of time to keep on wasting, you know. Yeah, the result is indeterminate. So you send another gene expert and it comes back indeterminate again. You know, you do an X-ray and the X-ray doesn't show you. You do sputums are negative in this patient. What are you going to do? So definitely, if the patient is gaining weight and so on, you can try antibiotics in this patient, start ART and see what happens. That's what I would do. I would start this patient on ART. But I don't think this is one of those cases where you have an exact science, because really it's dependent on the situations that we have. And in this situation, maybe it would be prudent to start ART, you know. Yeah. Because of the question that the person asked, the last question, that, you know, patients who are not started early are usually lost to follow-up. We miss these patients. So you don't want to reach a point where you can't have an explanation to what has happened to this patient. Start the patient on ART, keep them in care, and monitor closely.
Thank you very much. We've got another contribution from Dr. Zico. So Dr. Zico, you can go ahead.
Okay, my contribution is that this is a patient that you'd also want to closely liaise with the lab. You mentioned that in your district you only have one gene expert machine, and it's obvious that you probably get your turnaround time for your expert results is high. So I think seeing that a sample was collected and you didn't have results for that patient, and the patient has resubmitted, there's also an aspect of anxiety on the patient. The patient obviously doesn't know what's happening. This is one where you can actually send the sample yourselves as a facility and then communicate with the lab, and you should be able to get the result within even a day if you expedite the result, because a gene expert sample should only take about 2 hours to process. And so if you prioritize this patient sample, you should be able to get the result and have an answer concerning the TB within the shortest possible time.
Dr. Zico, I think just putting you on the spot, with the study that you did in pneumonias, what did you find was the kind of commonest among our patients that we see in terms of what organisms?
So my study population, 70% of them had actually HIV. I was looking at the causes of respiratory disease in the patients. And the commonest cause of respiratory disease in the patients was actually TB. The other causes of community-acquired pneumonia were much less. So in this study population that I was looking at, TB was the commonest, and it's possible that we may have similar results in other facilities, but that's something that needs to be further investigated. So we need to also see how primary health care patients present with regard to pulmonary disease.
All right, thank you very much. Prof, would you like to add anything?
I think I would agree with Dr. Sivile. We have delayed, I think we have even failed this patient. We could have had the result much, much earlier than waiting for this time over the gene expert, which they should have sent even a second sample within a short period of time. For now, my advice would be the patient to be initiated on ART. Even when the patient is initiated on ART, we monitor closely, and also when we have the results, they can be initiated on TB treatment. We just have to monitor them as well when we initiate them on the TB treatment. So this patient should be initiated on the TLD. If they have TB confirmed, then they'll just need to add the DTG as a separate dose and continue with the ATT. We should not delay because we may lose this patient. Either the patient does not come back or the patient may even die. So my emphasis is that this patient should be followed up and start treatment.
Okay, thank you very much, Prof. And I think there's a concern that why can't other tests like full blood count, ESR be done? I think that the only reason is that this is a primary health care facility, and most of the tests actually might not be available, including just X-ray. So that's why if this patient has to receive the other supportive investigations, they have to go to a bigger center. And I think that's what Nathan was trying to explain earlier. There is another question though from the network challenge in particular, where they're trying to find out, are there circumstances where the expert is positive and the culture is negative? Dr. Sivile, have you ever come across such results?
The expert is positive and the culture is negative. So this would be maybe someone who was treated before, theoretically that is where I've never come across such. I've come across the other round, expert negative, culture positive. Yeah. So this is where you have the DNA, but the bag is not viable, so you can't culture it. Yeah, so that's theoretically possible.
So probably maybe in the initial stages of TB treatment, maybe in the first 2 weeks, where there's rapid clearance of the mycobacterium, but such circumstances normally are rare without treatment. We will now go to the second question, Dr. Sivile. Was it appropriate for the center to start cotrimoxaz or prophylaxis before the baseline CD4?
I think, yeah. I don't know what this cotrimoxaz was prophylaxis. So this has been the practice in the field, that you find someone positive because we can't do a point of care CD4 count, you give them cotrimoxazole. Then if at all the CD4 comes out to be fine or high, you stop the cotrimoxazole. And I don't have any problem with that in view of the many benefits that cotrimoxazole does give. You know, this is, in other places, you find that before someone is started on ART, some people are given azithromycin and so on, and in some antibiotic, and that has shown to have some benefit. So I think it's because we don't have point of care tests for CD4 counts widely available. So it's correct. Just make sure the CD4 is done, and if it's above 500, just follow the guidelines, then you can stop the cotrimoxazole.
Yeah, just on the same, there is a concern that their turnaround time for CD4 results is actually very long. So does this quite happen oftenly, Nathan, at your facility? Unmute you.
Dr. Peter, can you hear me?
You can. Yes.
No, it's not really quite often. In most cases, within 2 weeks, we get the results. We actually have a dicer link, so we get them through a dicer. Unless in an instance where you've not received some, that's when you can follow up. And most cases, we usually get results from UTH within 2 weeks.
Okay, thank you very much. I believe there is no other addition to the second question with regards to reception. Yeah, so we can address the last question. What appropriate measures do we need to undertake to avoid losing presumptive TB patients while waiting for their results? And I think briefly, Dr. Sivile had touched this together with Prof. So maybe you can just re-emphasize so that we can complete the questions that are coming from Ngongwe. Dr. Sivile.
Oh, yeah. I thought Prof would pick that one up. Yeah, so I think immediate or early initiation of ART will avoid losing these patients. That should be clear. You know, early initiation promotes linkage. Different trials prove that. So we need to, by all means, try and start these patients early on treatment, even when there's these fears of OIs. That's why I brought up issues of iris. I know that the fear is iris, but we need to remember that, you know, mortality is higher when you don't treat than when you treat, then iris comes, you know, because then you can attend to it. Yeah. So out where the systems are not perfect, and I agree with you, you don't have x-rays, you don't have what, then you have to use clinical argument. If you think this is TB, the decision should be made earlier. If you think this is TB, the guidelines does allow presumptive diagnosis of TB, you know, start the TB treatment, then start the ART. If you are in the fence, you don't know that, you are not so sure that this is TB, at that point, start the ART. I think that's the approach, you know, because we do have the allowance, even the TB guidelines, to have presumptive diagnosis. So if you are not so sure that this is TB, don't give it. If you are sure that this is TB, give the TB treatment. But in other words, you need to be thinking of expediting the ART, commencement. Like Prof said, even when you start ART, you need to start the even if you start the TB, you need to start the ART within 2 weeks, according to our guidelines. So we need to expedite the commencement of ART. But that decision of TB, people should commit a little bit more. There's no harm with, if you think it's TB, having a presumptive diagnosis of TB, where conditions don't allow for you to do a test.
Okay, thank you very much.
Okay. We are developing the advanced HIV guidelines, and we are going to have some point of care CD4 testing as well. Just on when you're in clinic, you just prick someone the way we do for the sugar, and also for HIV testing. So just a drop of blood. Then there will be indication on whether someone, they're based on a CD4 350 or CD4 200, but we are thinking of the one which has the threshold is 200. So if it's positive, we are using that point of care test, you know that this one has a CD4 of 200, then that can at least alert you that this is an advanced HIV disease person. So even the issues of prophylaxis, you can go ahead and also you can be on the lookout for opportunistic infections. I know one of the reasons on managing OIs is that we have delayed in having this document and also the trainings over this. We are trying to put in a lot of information into this document, which will be comprehensive. So there will be an advanced HIV disease care package where all the OIs are going to be discussed. We hope by October it should be out in the facilities.
So thank you very much for those clarifications, Prof. and Dr. Sivile. I will try to go through the recommendation with regards to the first question, whether we should wait after the resubmission of sputum for this patient to initiate. The experts have advised that we start ART A number of issues have been identified which are system issues with regards to the expert results, the chest X-ray, and other supportive investigations in this case. So we are actually employed to call upon higher facilities in terms of care so that this patient should not delay any further. The second one, whether it was appropriate to start Septrin, I think it has been agreed that yes, it was, especially that this patient presented quite with an illness. So we need to start Septrin, and then if the CD4 comes out to be higher than what is the requirement, then we can safely stop the Septrin. What do we do to avoid losing this patient who has got presumptive TB? Early insertion of ART is actually what is going to improve the linkage for this patient. And if we can start ATT, especially when we have got a strong suspicion for TB, let's start. And Prof has advised that the point of care machines for CD4 will be coming in due course, together with the guidelines. I have been told there's one burning issue. All right. Somebody wants to make a comment. We don't even know who it is. Sorry? It's showing MOQ6. Oh, okay.
Thank you. I'll make this very quick. So I just want to say thank you to Dr. Sivile. I really enjoyed this, some of the worries that we go through, and it really went through it in depth, and I appreciated that approach. I wanted to share also that just circling back to the issue of starting and it's starting ART and how how well we start affects how well a patient is able to be retained, right? So if we are able to offer them that effective post-test counseling, we're probably more likely to be able to keep them on treatment, provided, of course, the other infrastructural issues are taken care of. So there is an effort that as PEPFAR we are looking into and working on, which is this effort of trying to standardize post-test counseling using, a single binder where it starts from the beginning and then it goes to the end. But I think other partners have done this in the past, but what we're now really trying to do is use our PLHI CSOs who themselves have HIV and have gone through the process and the denial and the anger and all those stages that you go through when you first get diagnosed with a chronic illness. We're trying to see if we can use PLHIV CSOs to provide this standardized post-test counseling to especially those who are newly initiating on ART, because we know that they're the most vulnerable for all the reasons that have already been highlighted. So I know some of these presentations are going to be coming to the National TWG and will be discussed probably more on this forum as well. But just to say, just to put out there a thought for clinics, if you have HIV CSOs that work with you, let's try to use them to provide initial post-test counseling because they are likely to be the most effective because they themselves have personal experience with it. Thank you.
Thank you very much, Dr. Boyd, for your contribution. And I think you have really emphasized what we've been talking about today. And Dr. Sivile gave us actually why same-day ART is important, in that it reduces all-cause mortality. And this is actually without with regards to either opportunistic infection, AIDS-related mortalities or non-AIDS-related mortalities. We've also seen that it improves both immunological and virological outcomes in patients and also improves retention, which we are actually trying to ensure that we improve, and also as a transmission. A number of barriers have been identified why same-day ART is being hampered. And
This problem at the hub, I think.
Nothing until.
Yes, sir, can you come again? We were looking at our internet was acting. Maybe you can come again?
Yes, I was saying that
muted themselves.
That there will be a written recommendation which shall follow, but we want to know if everything is okay. Okay, we have unmuted you now. Okay, would you try to unmute from your end? Okay, go ahead now.
Okay, we're saying everything is okay. The only guidance we want is the issue where we have a case we're suspecting TB, but there's cough and other symptoms, but they might not be leading you to TB, but could just be a mere cough. So do you need to hold IPT until you do investigation with either microscopy, X-ray, or gene expert and start ART in that case? Because the practice is that the providers start ART and IPT at the same time when the client doesn't have symptoms of TB. But if there is symptoms of TB, they would wait, like in this case, they waited for a longer period waiting for sputum results. But the guidance now is that you have to start ART. So should we hold IPT in that case until...
Okay, thank you very much. I know maybe Dr. Sivile would have loved to say something. Yes, remember the requirement for starting somebody on IPT is that they should not have symptoms for TB. So if you have not ruled out TB, yes, you cannot start IPT. And that's why it's important if tests like Gene Expert are not available and within time, the experts have advised that if we can refer to higher center for an X-ray and other microbiological tests that can actually aid in us making a prompt diagnosis in this patient. But where that is not feasible, please start ART as we try to establish the diagnosis of TB. But we should not start IPT when the patient has got a possibility of having TB. So thank you very much, everyone, for joining. And next week, we shall be discussing the concept of undetectable is equal to untransmittable. U is equal to U. And we shall definitely appeal for anyone to submit a case that will make us discuss this topic next week. So from me and everyone in the hub, have a lovely week and see you next week, Monday. Thank you.